society converged. Prior to data.org, Danil was at the Wellcome Trust, where he founded and directed the Wellcome Data Labs, an interdisciplinary team of data scientists, software developers, and social scientists, creating open source data tools supporting Wellcome's mission. While at Wellcome, Danil coordinated the data and data science aspects of the Trust's COVID-19 pandemic response. And before joining the Wellcome Trust, Danil founded and chaired the Digital Strategy Forum for Science, Art, and Culture in the United Kingdom. He strongly believes in the power of interdisciplinarity, and in addition to his tech expertise, he brings a social sciences and humanities perspective to his work. Danil holds a PhD in sociology and communication from the University of Brunel, an MA in philosophy from Birkbeck, University of London, an MA in Chinese studies from SOAS at the University of London, and a Bachelor of Sciences in IT and Business Management from the University of York. And again, as a reminder, if you have any questions for any of our panelists, please add them to the chat, and we'll go through them during the discussion after all of our speakers have presented. So, Danil, over to you, and whenever you're ready.
Thanks for the fulsome introduction. Let me share my screen. It's really good to be here. Hopefully you can all see my screen now.
Yes.
Perfect. Well, thank you very much for inviting me to speak. Really excited to be here for this session. I will talk a little bit about Datadog's program called Epiverse. But before that, let me just introduce a little bit about Data.org and who we are. So we are a nonprofit organization founded about 2 years ago. And what we do is support the use of data science and data for social impact by different sectors, both in health and climate, in financial inclusion, in social justice. So we are sector agnostic in the way we do this. We work across 3 modalities. We look at supporting cases, fundamentally for good. We support capacity building, training of the next generation of data scientists in different sectors, and we support the commons, which is where the Epiverse program is part. So that's the building of public goods, various open source software, tools and infrastructure. So just zooming out a little bit about to understand what is the problem we're trying to solve connected to infectious disease, epidemics, not just, of course, COVID-19. But COVID-19 has taught us a few things, which I think a few lessons which are generalizable. One, we have learned painfully how fragmented our data landscape is across the world. Data tends to live in silos. Systems are not interconnected. In many cases, data just doesn't exist in many countries. So there are both gaps in data, the lack of connectivity where data does exist, and various barriers of access, which I'm sure we'll get into in much more detail across all our presentations today. Solutions and tools for processing that data are also not standardized. So beyond the fact that data is siloed and hard to access and find, tools to process that data, create models, analyze it, often not standardized. Typically, modelers in epidemiology tend to hand code their own tools in other packages. Often it's the junior most member of the team, a postdoc, that does a lot of the code creation. And that software is, unsupported, undocumented. It works in most cases, which is good, but it's hard to reproduce because it doesn't have that support. And it's always under threat. Those tools are often under threat of not carrying on when funding for particular projects expires. So we have a real problem in how tools and software for processing of this type of data is actually supported for the longer term. We have problems with standards. So often solutions are created with lots of duplication, using different approaches, different standards, which makes integration even more difficult. And finally, I would call out the problems with the lack of skilled data science talent, both as a whole, as a quantum. We don't have enough great trained data scientists. We have problems of incentives in particularly in academia, where the work of data scientists and software engineers who often create the models, create the surveys, process the data, isn't fundamentally as valued often as more traditional academic work, such as publishing papers. So there are real structural disincentives in careers for folks who have great talent and skills in the technical areas and want to specialize in them, which of course means we have an undersupply and availability of data. And those of them who do specialize in data science often are poached by the private sector because of the huge disparity in salaries. So we have a continuous brain drain from the academics sectors of this talent. And finally, this talent is not diverse enough, and it is not equally distributed across the world. We have a lot of great data scientists in the global north, which is excellent in London and New York and San Francisco, Seattle, etc. But a real undersupply of capacity in low and middle income countries, often where, of course, endemic diseases, epidemics start, and where we need people at the front line who are able to bring their talent to bear. So these are the problems: lack of coordination, lack of standardization, lack of supportable tools, lack of talent. In terms of solutions, so we need the reverse. We need better coordination. We need to bring together, networks of philanthropies, tech partners, academic partners, government partners, in order to solve some of these issues in a more coordinated way. So we avoid duplication. One of the things I remember during my time at the Wellcome Trust in my previous job, as was said in the introduction, when the pandemic hit, we had calls from every tech company. We had calls from the best kind of academics in the world, offering solutions, often duplicating each other, 3, 4, 5 examples of very similar solutions being launched in order to solve this urgent crisis. But of course, the issue then is, how do you begin to coordinate this? How do you begin to join people together? So I remember we did a lot of work, both at Wellcome Trust and in our partners and other philanthropies, like the Gates Foundation, for example, Chan Zuckerberg Initiative. We worked together very closely to try and introduce coordination in the space, try to link people together. So if you have 2 calls from different people offering similar solutions, we tried to bring them together and connect them to each other, so they offer kind of a single solution. We tried to encourage coordination, collaboration. So one example is I remember with the Bill and Melinda Gates Foundation and the Wellcome Trust, each had applications from great data repositories for extra funding to support the work on COVID. And we again put them together to make sure that the application was processed in a coordinated way. So fundamentally, we as a condition of the grant, got the data repositories to actually work together to solve problems coherently. So that kind of work we did ad hoc during the pandemic. But of course, the better way would have been to do it before the pandemic hit. So we had what we want is a system which is coordinated in advance of a crisis, not trying to coordinate during a crisis hitting. We also need to begin to, apart from coordination, amplify outputs. We need to scale them. We need to generalize them from sectors. So often, lots of work in this area is niche and small scale. How do we actually support the best projects and allow them to scale? So we have standardized, global, open, freely available tools which everyone can use, rather than multiple versions of the same tool, often with a small niche amount of users. And we need to invest in talent. So again, the reverse of the previous slide. We need to much more investment in talent, particularly in low and middle income countries, where we have the need, because that's where a lot of the endemic diseases are happening. That's where epidemics rise. That's where the next pandemic is most likely to happen. How do we help invest and build capacity on the ground, local centers of excellence, to make sure that we have the people when the next crisis happens? So what is Datadog doing about it, and why am I speaking in the first place? So we, because our purpose is to convene and coordinate and invest in data science capacity for good, when the pandemic was in flight, we identified one particular area where we thought we could intervene, and that was the creation and support of open source software for epidemiologists, to try to solve this issue of having lots and lots of kind of local bespoke efforts, and instead bring together networks of partners in academia, in philanthropy, in tech, to create a suite of open source standardized tools, which are then freely available to the sector, to the whole sector, both academia and, of course, in-country teams in ministries of health who are trying to use those tools to analyze data in order to generate good policy during both during that pandemic and hopefully in future for other diseases. So we together have invested a lot in this tool creation. I'm going to talk a little bit about this project as an example of what can be done. So the Epiverse program has 3 pillars. The main tool building is happening in the trace pillar, where we're working to both create new software, open source tools, both to integrate data, prepare and clean data, visualize data, and do the analysis, but also look at existing tools to make sure we avoid the very problem we're trying to solve, which is duplication. So part of our method is to reach out to communities that have existing tools out there and work with them to support them and build on top and build in a way that is coordinated with them. In the build pillar, we have launched a number of challenges to try and solve problems and invite other teams to collaborate with us. And in the connect pillar, we are looking to map out other efforts to make sure that we are clear how what we are doing fits into the larger ecosystem. So I've talked a little bit about trace already, but the key aspects of that effort is it's not just about funding the creation of tools, it's about where those tools are created. So fundamentally, we're funding the building of the software in low and middle income countries in particular. So we were very keen from the beginning to make sure that the capacity is invested, is grown locally. So we have great tool building teams that we're funding in, for example, the Gambia, in the MRC unit there, in Colombia, like Universities Javeriana and Los Andes, and as well as the UK, in the London School of Hygiene and Tropical Medicine. So we are making sure that software is created internationally, the teams are coordinating with each other, and specifically we were keen to make sure a lot of the software is built in low and middle income countries. In addition to funding the creation of those tools, we're funding the building up of the community around them. So for those of you who work in open source will know that just building some tools and releasing some code on GitHub is nowhere near enough to make those tools usable and adoptable, and then to be a living set of software that is supported for the future. So we also invest in community building, for example, hosting events for the community of software developers and data scientists across the world, invest in good quality documentation, in testing regimes and codes of conduct. So all the kind of supporting material that a community requires to exist beyond the software itself. And finally, we're investing in the adoption of those tools as products by countries so that the tools are usable, not just by data scientists, but by data literate analysts working often in ministries of health in different countries and using analysis to produce policy. So we want to make sure the whole pipeline from the creation of the tools to the use of tools is supported. In the second pillar in the build, I'll give you one example of what we're doing. We're trying to unlock new data sources for the use of epidemic analysis. In our case, we're working with private companies to unlock financial transaction data. So we had great examples of the use of non-traditional data like mobility data, for example, during the pandemic. We want to add further data layers. So we're working with financial transaction companies, credit card companies to unlock that data type for epidemic analysis. Fundamentally, it's important because in many parts of the world, there are no electronic health records, and health data is very sparse. So you need other alternative data sources, and financial transactions is a good proxy because, for example, you can tell at merchant level where there is a spike in the sale of fever drugs, which can be a proxy signal for change in the course of the pandemic. So even in those countries, in those regions of the world where you might not have easily available health data, you can use data from financial transactions as a proxy. So one of the things we're trying to do is work with those providers to create ways to unlock that data safely using privacy-enhancing technologies like differential privacy. That is a significant effort and will take, I have no doubt, a number of years to properly test and get right. So one of the approaches we're taking is we will be having an open call probably in 2023 to invite the best teams in the world who specialize in differential privacy and other PET, privacy enhancing technology approaches, homomorphic encryption, for example, to compete for a set of prizes that we will be funding in showcasing how their technological approaches can safely unlock, while preserving privacy, financial transaction data at aggregate level, and make it available, retain the signal, if you like, for epidemic analysis. In Connect, we are working with a number of partners like Path, like Digital Square, like WHO, to help bring together a number of disparate mapping efforts to produce a series of public goods where we are mapping all existing epidemic analysis software and infrastructure projects out in the world at the moment. So one of the issues we're trying to solve there is we are aware through our networks how many efforts are in flight at the moment, triggered by the pandemic. We know there's plenty of overlap between them, but also plenty of complementarity. So as a kind of service to the sector, we are trying to map all those efforts, visualize them, and show how they are interconnected with each other to make it easier for the community to kind of find partners, find collaborators, and become more coordinated. So that work is happening at the moment, and we'll be releasing, hopefully, our initial public goods soon. And finally, capacity. So in terms of tools are useless if there are no people who can actually apply them and use them on real data on the ground level. So a lot of the work of data.org is also to fund local hubs around the world where we are working with educational providers, academic institutions to teach data science, but teach it in a new way. So we are looking at more interdisciplinary curricula which are more specific to the data. So for example, in this case, public health data, where students will be taught whether at master's or bachelor's level skills, not just the technical skills, for example, Python, statistical analysis, etc., but also skills from the social sciences, how to work, for example, with vulnerable communities, how to take account of consequences which are specific to health data. So those courses will be done in partnership with academic institutions, and we're currently working with a number of providers to launch them in Sub-Saharan Africa, particularly in West African countries and in India, and hope to do the same in other regions of the world. But it's very important for us that we reach students who are spread more evenly across the world, particularly in low middle income countries, students who are more diverse in terms of gender, in terms of race, students who have more interdisciplinary skills. And we aim over the next 10 years to train and help catalyze the training of, by other partners, of 1 million of purpose-driven data professionals across multiple sectors. Just a few examples of our collaboration. So as I said, one of the things we're trying to do is bring networks together to avoid single points of failure. So for example, in philanthropy, we're working with multiple funders. In building, we're working with multiple building partners, different academic teams, different tech companies. And we work with great partners in WHO, for example, the Berlin Hub team, work with the G7 team, particularly the UK team, where the pandemic was a key kind of priority for the UK government during their chairing of the G7, as well as many, many others. So these are just a few examples of our collaborators. And some of them are on our advisory council, but we always welcome other partners. So I very much encourage those listening, if you're interested in what we do, to reach out, and we hope to work with you in open collaboration. Thank you for listening. I'm happy to take questions. Thank you.
Great, thank you so much for that excellent presentation. And if you, again, a reminder to everyone as we go along, if questions are coming up along the way, please feel free to ask them in the chat, and we'll try to connect them and then facilitate discussion amongst the panel at the end of the session. But thanks again for such a thorough introduction to all of your team's work. Our next panelist is Matt Ferrari. Matt is a professor of biology, the Dorothy Four Huck and J. Lloyd Huck Chair in Global Health, and the director of the Center for Infectious Disease Dynamics at Penn State. His research focuses on the use of quantitative modeling and statistics to support monitoring and evaluation for vaccine programs in humans and livestock. The title of Matt's talk is Rethinking Diagnostics for Public Health. Matt, over to you, and thanks so much for joining us. I know you're in the midst of the other conference that was mentioned this morning, EID, as well. So thanks for taking the time.
Yeah, thank you, and thank you to the organizers. Just checking that you can hear me and see the slides. All right, excellent. Yep. So yes, thanks to the organizers for the opportunity, and yes, my apologies to I've actually been able to join for all the speakers today, but I wasn't able to do so yesterday, and I look forward to seeing the recorded talks, which I hear have been excellent. So let's see. Hopefully all this will work. But so I'm a consumer of surveillance data, and it's because of that I have a lot of opinions about what the challenges to those data are, but have been increasingly thinking about how we as consumers can try and offer solutions to make those data better, more effective, and more efficient. And so I can't tell you how many times I've heard this phrase in the context of the use of diagnostics. And really, this comes from a traditional view of diagnostics as predicated as an individual medical intervention and for individual medical good, right? So classically, we think of a diagnostic result that can change the course of treatment for an individual. But what I'd like to do is change that, and through the course of this talk about how a diagnostic result might also reduce the risk of transmission for others, either because of an individual intervention on that patient, or perhaps because of the information gain that would help to facilitate a population level intervention. And this really isn't a new concept. There's a long history in sexually transmitted infections and in Ebola, right? Of using diagnostic testing to facilitate isolation, quarantine, and better target non-pharmaceutical interventions. But this has historically been comparatively rare for respiratory infections. And I think that the experience in COVID over the last couple of years has changed some important things about the perception of the use of diagnostics, as well as perhaps the production and supply chain. The perception, we now see the ease of use and access to diagnostics, and the potential for ease and access to overwhelm some of the traditional concerns we have about diagnostic performance, and again, emphasizing the potential for indirect benefit, actually using diagnostics and treatment as a health intervention itself. But also importantly, what has also changed is the production and supply chain. The market for diagnostics has changed, with tests now available in the home that are the same as those in the clinic, at least in some parts of the world. And I think this presents an opportunity for expanding the role of diagnostics and access to diagnostics the world over, as we heard in the keynote talk earlier today. So consider, right, diagnostics in the time of COVID. Universities, businesses, and even the NBA in the United States showed that high frequency testing can detect cases quickly and limit onward transmission. Right, so this is an obvious indirect population level benefit achieved by applying testing and diagnostics to individuals. So the case that I'd like to make for today is that there's also a powerful indirect benefit in that testing and diagnostics can provide stronger information for population decisions and public health decision making. So in that context, I'm going to give A quick example of one of the few COVID-specific projects that I was involved with. If you think back to early in the pandemic when testing delays were very, very long, indiscriminate testing could have a high opportunity cost. So consider the left-hand picture here. We've got people in line waiting for tests. The people in red are positive. And if you test people at random, some individuals who are currently infected might be long in line and therefore can't access care, but also don't get isolated quickly, right? Right. But each test done was an opportunity to inform a clinical decision model, to identify what the characteristics, especially with a new and emerging disease, what the characteristics of infected individuals were, what the clinical case definition was, and could actually be used to identify those individuals faster, prioritize them for testing and care, right, which helps both them individually as well as the population. And so in some work that was done with colleagues at University of Utah, led by Jody Reimer, she developed a clinical predictive model for COVID positivity based on symptoms. Here she used thousands of early COVID cases and fancy machine learning methods, random forest regression, to figure out which symptoms were most associated with COVID, and then proposed a probabilistic scheme to achieve the diagram at the right for prioritized testing based on symptoms, right? Putting those most likely to be positive at the front of the queue. And what this does is speed them along and provide faster care for the ill. But what Jody was a mathematical modeler, and what she did was also to show that if you take that phenomena and drop it into a population dynamic model of population level spread, that what this also does is it means that infected individuals are in the community for shorter amounts of time, and therefore putting others at risk of transmission for less time, and reducing the overall size and peak of outbreaks, right? So the thing here is now that an individual untested case now benefits from a decision model that is informed by individuals that were tested previously, right? So we have this now indirect and delayed benefit of the diagnostic, right? An analysis of testing data can also then lead to policy changes that increase the indirect benefits for the population overall, not just in terms of speeding individuals into care, but also in reducing the size and magnitude of outbreaks, right? So again, what I like to focus on for the rest of this is this indirect and information benefit of diagnostics that we're increasingly recognizing. And I spent a lot of my time worrying about the application of vaccination and outbreak response, right? Outbreak response is a classical indirect benefit. We're trying to stop or slow down an outbreak. But unfortunately, the information that we need is often limiting. The clinical case definitions, so clinical observations of individuals with symptoms, syndromic surveillance, is fast, but it's oftentimes non-specific. Things like acute flaccid paralysis, influenza-like illness, or febrile rash might be indicative of a polio outbreak, a flu outbreak, or a measles outbreak. But they also might indicate other sources or other etiologies, right? So it's possible that that clinical definitions alone may lead to overreaction with limited outbreak response resources. But nonetheless, again, observed cases are symptomatic of an outbreak, and we know that early and effective action is necessary, right? The classical phrase, the time is of the essence in outbreak response. And so the faster you can move, the better. Right. So from the rest of the talk, everything I'm going to talk about is going to be about measles. That's where I spend most of my time thinking about, right? And measles has a classically non-specific clinical case definition: fever, rash, and cough, runny nose, or runny eyes, right? And anyone with small children can recognize that that's a pretty common set of symptoms and a pretty common syndrome seen in young kids around the world. Right. So unfortunately, in many high burden settings, so here's an example of a project that we're doing in DR Congo, diagnostic confirmation to prove that a child has measles can oftentimes take a very long time. The gold standard that's used in the field is ELISA, but transit delays to get samples from point of care to the lab are oftentimes severely limiting. Here, what's shown on the right are the cumulative distribution of transit times from point of care to the National Reference Lab in Kinshasa for different provinces in DR Congo. And as you'll see, many of these are oftentimes longer than 2 weeks to get a case even received by the lab before it can be confirmed, right? And so that puts us well behind the ball in outbreak response. Rapid diagnostic tests have been proposed as one solution, but concerns that they don't achieve the sensitivity and specificity of the gold standard have limited even feasibility trials for some of these things, right? And I would submit that really the only barrier here is the perception of these diagnostics in terms of their individual use, rather than their applicability at the population scale, right? Now, I'm just going to take a brief aside here and say that I would be remiss if I didn't acknowledge that this isn't all about rapid diagnostic tests. And in fact, improving access to diagnostic services through conventional means is also a really important part of this story. And here's just a simple illustration of this, that following the development of a new diagnostic lab in Lumumbashi on the eastern part of DR Congo, we went from the distribution shown in purple to the distribution shown in yellow. So a 10-day reduction in mean transit times using conventional technologies simply by opening a second lab, right? But at the end of the day, the median here is still often 2 weeks between sample collection and sample confirmation, right? So again, point of care testing, and possibly through things like RDTs, could lead to a much faster outbreak response and achieve these indirect and population benefits of fast campaigns. Right. So lower test sensitivity and specificity can be accounted for by statistical models of inferred cases and alternate triggers. Right? I'm going to break down this statement, right? The first part, inferred cases, imagine that 3 RDT positives collected over a small number of days may quite reasonably include 1 ELISA positive with very high probability, right? And if you can get three RDTs in a few days versus 1 ELISA over several weeks, right? You can be much, much faster, right? But to use that, we need to think about changing the triggers we're using. Classically, we say we act if we have seen X number of confirmed cases. And in fact, we really need to change this to something like we can act if the probability of X cases is greater than some threshold P, right? So again, it requires that if we're going to use tests in a different way and use diagnostics in a different way, we also need to change the decision structure that we're using to trigger action, right? But diagnostics are not only about warnings and triggers, right? They can also greatly improve our situational awareness in routine settings. So what I'm going to talk about for the rest of this is now the application of diagnostics in routine settings to inform things like estimation of burden, targeting of resources, and evaluation of program performance, right? So again, burden of disease is something that I've spent a big part of my career doing, working with, developing statistical methods to take reported cases to estimate the burden of disease, right? We oftentimes have to accept the counts that we're receiving, right? But unfortunately, this is oftentimes going to comprise some mixture of clinical cases and diagnostic confirmation, right? Universal diagnostic confirmation would be fantastic, but it's currently infeasible in most settings. And until it is, right, there might be limited motivation for diagnostic confirmation. However, what I'm going to propose is that in fact, we can use diagnostic confirmation even at a small scale to develop clinical prediction models informed by by the scale of diagnostics that can currently be done, to help merge clinical surveillance and diagnostic surveillance into a more informative hybrid estimate and to provide better estimates of the state of the world and inform decision making. Right? So again, consider the case of measles, right? How much of the febrile rash that we see out there in the world is attributable to measles? Here's an illustration on the right for 9 of the highest burden countries in the Afro region from 2015 to 2020. The majority of suspected measles cases had not been tested. There are these gray boxes. These are cases that meet the clinical case definition of measles, but were not tested for IgM positivity, right? Shown in red and in blue are those that were tested, right? So we have all this gray area, both literally and figuratively in this figure, right? But, right, there is information in those individuals that were tested, not just in the test positives, but also in the test negatives. And we can use the ratio of test positive to test negative to help us filter through everybody that's in the gray area to come up with a better estimate, a hybrid estimate of the total number of cases that are out there. All right. So I'm gonna build up a schematic illustration, a cartoon to sort of illustrate this principle. Right. So first, consider all clinically compatible cases that are observed at the clinic. That's this set of boxes in white, right? And now there's also an unknown true burden of measles out there in the community, right? And these are going to overlap somewhere, right? Where now the white indicates non-measles febrile rash that meets the clinical case definition and would be normally reported as measles, right? And in the gray, the true reported measles cases that have been seen in the clinic, right? And I want to note that, in fact, most of this disease is actually happening in the community and not being seen by the health system at all. That's a separate problem for us to deal with, right? But for the moment, we just want to get better accounting of those cases that have been seen and documented in the health system, right? So if you notice, if we actually only use the suspected cases, the clinical case definition, right, we'll actually overestimate the total number of cases that have been seen and perhaps may lead to biases in the number, age distribution, and spatial distribution, because these are now including other sources of febrile rash, right? But if we were to even do a small amount of diagnostic confirmation, right, we could definitively know the relative proportion of test negative and test positive among those individuals, right? And those individuals, those proportions could then be used to estimate the proportion of the untested individuals who would be positive if tested, right? And so now we can come up with a hybrid estimate of burden that combines the known positives in red with the inferred positives here in gray, right? And in the language of big data, what we've really just done here is we've done supervised learning on those individuals that were confirmed diagnostically, and then we've taken that supervised learning model and applied it to unknown individuals to distinguish the expected number of true measles cases among the white and the gray areas here, right? Now, of course, it's naive to assume that all symptomatic individuals have the same probability of being positive. We might expect those rates to be quite different for children and adults, say, especially for something like measles, which is a perfectly immunizing infection. So older individuals may be less likely to be infected with measles, right? But what we can then do is fit statistical models, right, to the rate of positivity as a function of various different kinds of covariates, age, and other things, right? And so here we then create this histogram that gives us a now predictive model of your likelihood of being positive, given that you present with symptoms as a function of your age, right? And then we can capitalize on standard methods from statistics and data science to try and make the most of limited testing, right? We can capitalize on correlation in rates among similar ages, among neighboring regions, and among sequential time that can allow us to make the most of limited data, perhaps districts or regions that lag behind in diagnostic capacity can be informed by their neighbors if we make assumptions that their patterns there might be similar to their neighbors, right? So we don't need necessarily high volume testing everywhere to still account for local variation and highly specific models at the local scale, right? So what I now want to do is present a couple of case studies of applications of this to data from Ethiopia and Mongolia to give you a sense of what this might mean in a practical sense, right? So here's a time series shown of reported cases in Ethiopia. What's shown in blue are all febrile rash cases. These are the cases meeting the clinical case definition. In red are all those that tested positive, right? Over this period from 2009 to 2017, there were about 45,000 cases that were clinically compatible, that met the case definition, right? Only about 13,000 of them were confirmed diagnostically. And if you look here, so that's 32,000 cases that are uncertain. But among those tested, slightly, less than 50% of them were actually test positive for measles, right? Which implies that among these 32,000, right, less than half were probably true measles cases. And so what we can do is look at the characteristics of the test positive cases. We see that the proportion of those cases tested, the proportion that were IgM positive drops precipitously with age from birth to 5 years, but then actually increases over that time. So adolescents and adults with febrile rash, if they present, are more likely to be measles positive than otherwise. And that perhaps makes sense because there are many sources of febrile rash among children. Right? And certainly individuals that were vaccinated or had a history of vaccination were much less likely to be IgM positive, but not exclusively protected. And those individuals that were unvaccinated were much more likely to be measles positive, right? So combining this, you can see how a statistical model could be built up that says a 5-year-old with a vaccine history has a very low probability of being IgM positive, while a 2-year-old with no vaccination has a very high probability of being measles positive, right? And similarly, these patterns vary over age, right? Cases tended to be older in the north of Ethiopia than in the south, and they were more likely to be vaccinated in the west of Ethiopia than in the east, right? So again, we can capitalize on these patterns and correlations to try and now build up a much more specific model. And this was some work that was led by a graduate student at Penn State, Shosho Lee, who's now Dr. Lee. And she fit a logistic regression to the 13,000 tested cases where the outcome was IgM status and used inputs of age, vaccination status, and district. But the innovation here was that for each district, she allowed the coefficients of this model, rather than fitting each district independently, she fit their coefficients as a smooth Gaussian process. And what this allowed for was correlation in values and correlation in the pattern in neighboring districts. And this was really quite important because some districts had much lower rates of testing than others. Some had completely missing data. And so using conventional models wouldn't have been able to be fit. But by borrowing strength